Hello everyone. Welcome to another one of the GPSN 2025 4C revision lectures. My name is Eric, and I'll be presenting this revision lecture on your ENT conditions. Um, I was the rural representative for this year's GPSN committee, and I would just also firstly like to shout out that I think we have committee applications open. So if you guys are keen and looking to apply, I would encourage you to do so. It's a really great position. You meet lots of people, and it's good for your CV. So I'd recommend it. Um, and yeah, let's get started. So I'll be talking about your ear, nose, and throat conditions in this lecture. Um, kind of separated them in this way, and just as a reference for the matrix conditions that are actually included under ENT, in the 4C matrix. Just wanted to note that I won't be covering crew, or laryngotracheal bronchitis, as I think that will be covered in a PEDS. I think that's part of the PEDS matrix, but that is technically an ENT condition and certainly one that you guys should know about because it is covered on the exam. So we'll start off by looking firstly at ear anatomy. So in terms of the external ear anatomy, there isn't too many notable things here besides from, I guess, the tragus and the antitragus, which kind of protect the auditory canal. Um, I guess the tragus is what you use during your whispers test to kind of obfuscate one ear. And additionally, we have, I guess, the helix of the ear here, which is your kind of outer cartilage of the ear. This is where you can get costochondritis, which is inflammation of the cartilage and connective tissue of the ear. So this will appear to be erythematous and swollen in that case. And I guess the last thing in your external ear anatomy is the mastoid process, which lies just behind the ear and is that kind of bony landmark that you use to conduct your René's test, to test for bone conduction of sound. Moving on to the inner ear anatomy, following your ear canal, you have your tympanic membrane, which is where sound reverberates and connects to your cochlea, which is something that we'll touch on a bit later on. But the cochlea is essentially the main organ that you have in your ear, which converts sound wave vibrations into neural input that is processed in the brain as sound. In your inner ear, you also have your semicircular canals, which are essentially the canals that are responsible for, I guess, sensation and experience of balance. Again, we will touch on these a bit later when we talk about BPPV, but essentially each of these are have provide sensory inputs to the vestibular nerve for the semicircular canals and the cochlear nerve for the cochlea. Um, and these combine into the vestibulocochlear nerve, which is cranial nerve number 8, which provide this sort of sensory input for the brain. And then in terms of what you see on the otoscope, you have these certain landmarks in the ear, like the incus bone, which you can kind of see back here, and the pars flaccida, which is kind of the fleshy, I guess, fleshy tissue that kind of sits directly behind the tympanic membrane. Um, and I think those are the main things. Like the incus is kind of one of the landmarks you should be able to see. And then the other thing is the cone of light, which is typically reported as like a light reflex on your examination. So typically there should be a positive light reflex. Whoops. And if that isn't present, that indicates that there may be some bulging behind the tympanic membrane, which is leading to a like kind of refractory error. I'm not actually sure if that's the correct word, but basically like the cone of light can't be reflected as normal. So before we begin, I thought I'd just start off broadly by talking about the Rene and Weber's test, which are one of the important components of the ear examination, following obviously inspection of the outer ear and its landmarks, and also the whispers test. So after you perform the whisper test, and the patient may have failed this test or have an impaired hearing that you note on this test, you follow up by performing a Rene and Weber's test, which can help to distinguish between what sort of hearing loss? So if this is a conductive hearing loss, which essentially conductive hearing loss, I didn't write it here, but conductive hearing loss refers to any issues with sound actually reaching the tympanic membrane. So this may be some sort of obstruction, such as with earwax or with some sort of tumor, in the ear canal, which impairs the ability of sound waves to reach the tympanic membrane, or sensory neural hearing loss, which is an issue with, as I mentioned earlier, the cochlear nerve. So like impingement on that nerve or just impaired functioning of that nerve. So Renee and Weber's tests help to distinguish what sort of hearing loss we have and in which ear. So Renee's test, this is the one where you get your tuning fork and you place it on your malleus, and you see if air conduction is better than bone conduction, which is normal. So once you stop hearing the ringing of the tuning fork on your malleus, then you place it in front of your ears, and that should be greater. So if there is a conductive hearing loss, then bone conduction will be greater than air conduction. So once you lift the fork off your malleus, you won't be able to hear the ringing. Your patient won't be able to hear the ringing. And this is because in a conductive hearing loss, if there's an obstruction in the ear canal and the sound waves are trying to reach from the outside, they won't be able to, as much as if you place it on the malleus, the sound waves will basically kind of, the way I like to think about it is rebound off the obstruction back onto the tympanic membrane. So it'll actually feel a bit louder. Um, and then Weber's test is the one where you place the tuning fork in the middle of the basically head, in the midline of the head, and it helps to lateralize the side of hearing impairment. So in a normal Weber's test, sound should not lateralize to either side, it should stay in the middle. If there's a conductive hearing loss, the sound will appear again louder on the side that is affected. And in essentially with sensory neural hearing loss, the sound will be heard better on the normal side. So hopefully that makes sense. Feel free to replay that and rewatch that as many times as you need because it is a bit of a difficult concept that I even struggle with sometimes as well. This is how you do both the tests, and this is a bit of a diagram that hopefully helps to distinguish those. And there will be a question on that. I hope I can say that. There will be a question on that when we're actually doing the revision questions to help you guys get some practice on that as well. So make sure to show up to the GPSN revision questions day as well. The first condition we'll be covering is otitis media, which essentially refers to inflammation of the middle ear, typically caused by some sort of infective mechanism. The main risk factors for this are age, being between 6 to 24 months of age, being female sex, attendance of daycare, tobacco and air pollution, as well as indigenous backgrounds. The incidence peaks in the younger years of life, and this is due to, I wish I included a diagram of this, but because the eustachian tube, which connects the sinuses to the ear, um, that is shorter and lateral when you're younger. So therefore, it makes it easier for viral respiratory tract infections to be able to travel via the eustachian tube to the ear. Um, so you're at greater risk. And as you age, your eustachian tube becomes a bit more vertical and longer. So it's more difficult for your Otitis to transform into otitis medias. As such, a common clinical presentation is febrile illness following an upper respiratory tract infection. So that might be something that's included in the STEM. The most common causative organisms are virals like RSV, adenovirus, and coronavirus, but they can also be bacterial, which will be more serious on presentation, and they will also usually persist for longer as well. The most common clinical presentation, as I mentioned earlier, is a febrile illness with otalgia or ear pain, or a feeling of pressure in the ear, as well as potential hearing loss in the setting of a previous viral illness. Um, the signs may be a bit less specific, especially in younger age groups, as they aren't able to visualize or verbalize, sorry, their specific symptoms. But on examination, the child may present to be irritable and febrile. Otoscopic examination will reveal a donut sign or a bulging tympanic membrane, a negative light reflex with prominent dilated blood vessels, with decreased ability to visualize middle ear bony anatomy, as I mentioned before. So because of the effusion in the middle ear, you won't be able to see those landmarks that I mentioned earlier. You won't always get the prominent dilated blood vessels either. This is kind of what I'm talking about. So you have again your pars flaccida and your incus bone back here, but you can't really see those. Um, when you have an otitis media, it kind of looks like a bit of a donut, and you can't see your light reflex as well, like you could previously. So this is otitis media. This one's normal. Um, it's a very prevalent condition. Responsible for a lot of GP presentations, especially in children, up to 10%. It can be diagnosed with clinical history and examinations. You don't need to do further investigations, obviously, especially because it's usually children who are implicated in this condition. And we don't really like to poke and prod children too much because it can be very distressing for them. So, as such, management is often very supportive. This is also kind of concurrent with the typical viral etiology of otitis media, and it is usually a self-limiting illness. Most children will recover within 2 to 3 days. It may persist up to 8 days, but this is a bit less common. And treatment can be very supportive with paracetamol and or NSAIDs. Antibiotics are only indicated in very high-risk groups. Typically, these are groups that have a higher risk for bacterial infection or are likely to um, have a slower recovery period or whose otitis media may lead to hearing loss or developmental delay. So, antibiotics is only indicated in the following age groups. So, age less than 6 months, age less than 2 years with bilateral infection, indigenous background, children with otorrhea, so basically discharge from the ear with a potential for perforation. So obviously, if you have perforation of the tympanic membrane, that can be really bad for hearing. So you want to make sure to prevent those. But typically, you will only get otorrhea with a perforation because the I'll touch about more on that later when we talk about suppurative otitis media. Oh, sorry. Um, Because once the tympanic membrane ruptures, that's when the collection behind the tympanic membrane will be able to travel through the ear canal, and you will see that manifest as discharge. But yeah, if they have otorrhea, definitely give them antibiotics. Children who are systemically unwell, so they usually present as febrile, but if they are pale, irritable, and potentially they may have deranged vitals, um, they would be indicated for antibiotics, and children who are immunocompromised, so they have high risk for complications. If antibiotics are indicated, which they're only indicated if the children are in one of those age groups, then you can give amoxicillin, um, which covers for strep pneumoniae, and if they're unresponsive, they can be escalated to augmentin. Um, I don't know why I said co-amoxiclav, but yeah, augmentin, which gives greater gram-negative coverage. Okay, next condition is otitis externa, which is also known as swimmer's ear and refers to inflammation of the ear canal. So typically this is caused by swimming or traumatic injury to the ear, which may be caused by hearing aids or cotton buds. The patient will present with inflammation of the ear canal. This will be reproducible when you manipulate the tragus or not to the trachea, sorry, just like the ear itself. So you might just give them a tug on the ear, and since this actually shifts the position of the ear canal, this will reproduce their pain. You may be actually unable to enter the ear canal on otoscopy due to the degree of inflammation and swelling and pain that this causes. For the treatment of otitis externa, you want to avoid the causative agents, so swimming, hearing aids, cotton buds, tell them to avoid that. And you also would use an oral toilet, which is essentially just where you have some way of cleaning the ear. This may be with fluid or something else. Um, Typically it will be fluid in this case, since you can't enter the ear with anything else that might cause further trauma. Pharmacologically, you can prescribe them topical antibiotics um, in the form of eardrops with phramycetin or sulfamycin. You can also add gramycidin and dexamethasone, which is a steroid to decrease inflammation. Typically, I didn't include it here, but typically these come as like a combined therapy. I forgot the name for it, but you'll be able to find those online. If the person doesn't recover, you can try ciprofloxacin. And if they still don't recover from those treatments, you can consider a fungal cause, but that would be very rare. Um, this one isn't in your matrix, but I thought I'd just cover it anyways. So we're already talking about otitis media. This is chronic otitis media with effusion, so COME. also known as glue ear, and this is where you have a middle ear effusion for more than 3 months without other signs of infection or inflammation. So no fever, just this single symptom of otorrhea. It's usually associated with hearing loss, as in order to have an effusion, you actually no, that's not true. That's the suppurative one. And you can have some balance issues. Typically, there will be painless pressure in the tympanic membrane and conductive hearing loss. But this is often self-resolving. You may be able to see some fluid level behind the tympanic membrane. And for management, you refer to audiology if the loss persists for more than 3 months because of concern for developmental delay. You can give antibiotics if they're Aboriginal, Torres Strait Islander, um, or if they have Down syndrome or they have developmental delay. And you can also refer to ENT for consideration of grommets if it's not self-resolving. The next one is chronic suppurative otitis media. CSOM, as opposed to chronic otitis media with effusion, is different because in chronic suppurative otitis media, there has been a perforation of the tympanic membrane, so this will lead to your otorrhea, which is your discharge. Um, which is not healed over. So there's kind of chronic discharge from the ear. The pathogens become a bit more opportunistic than those typical to otitis media. For example, you may have Staph aureus or Pseudomonas colonizing the ear because there's no longer that, I guess, physical barrier of the tympanic membrane. Clinically, this will present as a painless effusion, and you may be able to see this on otoscopy. There will be long-term hearing loss, and this can significantly impact on language acquisition. The management is with ear toilet to dry and clear the ear, so you're not predisposing to further infection. Ciprofloxacin eardrops because gentamicin and I guess tobramycin as well is ototoxic and can lead to further hearing loss and damage to the structures of the inner ear. Um, if misdiagnosed, for which we prescribe pharmaceutin, it can be critical as aminoglycosides like gentamicin are ototoxic. So yeah, that's just a fun point, I guess. Not super fun. The next one is BPPV, which stands for benign paroxysmal positional vertigo. Um, this is caused by dislodged crystalloids in the semicircular canals, which lead to altered central neurological experience of balance. So in a less verbose way, essentially in your semicircular canals in the ear, these are responsible. I guess when you move your head, the crystals in your semicircular canals also shift, which give you an idea of positioning and balance. In BPPV, these crystalloids migrate outside of the semicircular canals. So there's like kind of a less accurate interpretation of balance. With sudden head movements, these crystalloids can be different in each ear, giving that position, that feeling of vertigo and imbalance. I hope that makes sense. So typically, BPPV will present with self-terminating episodes of vertigo that are caused by head movements. To diagnose BPPV, we use a maneuver called the Dix-Hallpike maneuver. I'll touch on this on the next slide, but this will result in nystagmus of eyes towards the affected side. And there is another curative maneuver, which is called the Epley maneuver, which we're essentially using to try to move these crystalloids back into the semicircular canals. The treatment for BPPV is with anti-vertigo medication, so you can give prochlorperazine or promethazine if symptoms are severe and if they have like nausea, vomiting. But BPPV may also self-resolve, and we can also try resolving it with these maneuvers that I'll talk about now. So your Dix-Hallpike maneuver is your diagnostic maneuver. This is where the patient sits. Okay, I'll just let you read this diagram here. And then once we've diagnosed it, then we can use the Epley maneuver to try to shift the crystalloids back into the semicircular canals, which will hopefully resolve the BPPV. The next condition is an R2, which is the cholesteatoma. So this is a benign but rapidly growing accumulation of keratinizing squamous epithelium in the middle ear. Uh, because it's benign, it's not typically the tumor itself isn't typically a concern, but it is a concern due to its implications for the other structures in the ear canal because you can destroy if there's rapid progression and growth of the cholesteatoma. So you may get tympanic membrane perforation or inflammation or chronic otitis media. You may, it typically will present with conductive hearing loss, foul smelling discharge, and recurrent ear infections. The cause of this is unknown, but it does require a semi-urgent surgical intervention. So management would be with referral to an ENT specialist for consideration of surgery, and this is what it looks like on otoscopy. And as you can see, it has become quite invasive, and I believe I can't see a tympanic membrane, so I believe that it may have been kind of destroyed by this cholesteatoma. Next condition is acoustic neuroma. This is also known as a vestibular schwannoma and refers to a slow-growing, non-malignant tumor that forms on the vestibulocochlear nerve. As I mentioned earlier, the vestibulocochlear nerve is primarily responsible for special sensation of hearing as well as balance. Which is cranial nerve 8, as I just Googled, just to make sure. And essentially, this causes unilateral sensory neural hearing loss associated with tinnitus and balance issues. So there's that classic triad of tinnitus, sensory neural hearing loss, and balance issues. Oh, except not vertigo. Vertigo would be what you would get in Meniere's disease. But hearing loss is typically your first symptom as it impacts on the cochlear nerve. As the tumor grows, it can impact other nerves like the facial nerve, and the best diagnostic imaging modality is with MRI, as usual when you're trying to visualize nerves. Treatment is advised by staging of the growth of symptoms, but it may involve observation, radiotherapy, or surgery, which is a decision that will be made at a kind of specialist level. The next one is labyrinthitis, which is not actually on your matrix, but something that does come up as maybe one of the options, so I thought I'd cover it anyway. Labyrinthitis is inflammation of the inner ear, and this also occurs post-viral upper respiratory tract infection. And commonly, it's less commonly a complication of otitis media or meningitis. So symptoms include onset of vertigo, tinnitus, and unilateral sensory hearing loss, and a feeling of imbalance. So keep in mind that these are the same symptoms for Meniere's disease, although I think Meniere's disease can also be bilateral. The vertigo lasts for more than 72 hours, and the hearing loss can be mixed. It can be mixed sensory neural and conductive hearing loss. If there's any other cranial nerve deficits, you need to rule out a cerebrovascular accident. So you need to rule out stroke. So, yeah, the vertigo lasts for less than 72 hours, but may persist as brief episodes for weeks following the episode. Physical examination will typically reveal nystagmus, and the treatment is mainly supportive with steroids if you have moderate to severe symptoms and prochlorperazine um, to manage the vertigo if that is also intolerable. Um, this is distinguished from vestibular neuronitis, which is by the involvement of hearing loss, because labyrinthitis also affects the cochlear nerve, whereas vestibular neuronitis only affects the cochlear nerve and the vestibular nerve, therefore hearing loss and vertigo, whereas vestibular neuronitis only affects the vestibular nerve. Again, this is also not a matrix condition, but just thought I'd include it anyway. And then Meniere's disease is caused by an abnormal buildup of fluid in the ears, which can disrupt hearing and balance signals to the brain. The triad of Meniere's is the same as labyrinthitis, so you get your hearing loss, tinnitus, and vertigo. The main difference is that Meniere's disease is typically episodic, and the episodes can persist for long periods of time, um, and they're not brought on by any specific trigger like in BPPV. The treatment for Meniere's disease is outlined there, but in the interest of time, I will move on. Um, so these are some of the causes for conductive hearing loss. I won't go over these again in the interest of time, but you can read them if you would like. And these are some of the causes of sensory neural hearing loss, particularly remembering presbycusis and noise-induced hearing loss, which I will touch on in the following slide because they are things that you will have to interpret on audiograms. So this is cochlear anatomy, which I should have potentially put earlier on in the slides. But essentially, normal hearing involves the hair cells in the cochlea vibrating when exposed to certain frequencies of sound. These, depending on the area of the cochlea that is stimulated, these will be transmitted as sound via the cochlear nerve to the auditory cortex in the temporal lobe of the brain. In presbycusis, which is age-associated hearing loss, there's a gradual loss of cochlear hair cells and spiral ganglion neurons, leading to hearing loss at higher frequencies. So these higher frequencies are on the outside of the cochlea. Um, just as kind of a fun fact, but I don't think they usually ask about this level of anatomy um, in the exams. This is an audiogram, which is something that you will be asked to interpret in the exams. Very quite straightforward to interpret. Essentially, you have your um, frequencies at the top of the audiogram, so high frequencies on the right, and then on your y-axis you have your hearing threshold. So being at the top means that you have normal hearing. The further down it dips, the less hearing you have. You also have your left ear and your right ear represented on this. So this specific pattern, as you can see, they have normal hearing at lower frequencies, and then their hearing tends to drop off as they reach the higher frequencies. This is most characteristic of presbycusis or age-associated hearing loss. And here are some of your things. The other thing to note is the dip at this specific frequency. So your noise-induced hearing loss is like this one over here, where you will get normal, 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 and then at a certain frequency where you've had that exposure to like a noise, like a loud sound, you'll get a drop and then it will come back up. So that will be a noise-induced hearing loss as opposed to the age-associated hearing loss. Okay, the next section is on the nose. So firstly, we'll be talking about allergic rhinitis, which is also referred to as hay fever. It's a type of hypersensitivity reaction that primarily involves the nasopharynx, leading to inflammation of the nose and the sinus mucosa. Risk factors is a personal or family history of atopy, just like with your classic asthma, eczema, and allergies. They all are risk factors for each other. Exposure to indoor allergens and maternal smoking in the first year of life. The pathophysiology is kind of similar to your other hypersensitivity reactions, but they occur following repeated exposure to an allergen, which leads to a lower threshold for inflammation to be triggered. Um, it typically presents as episodic sneezing, rhinorrhea, nasal obstruction, and nasal itching, and potentially like eye itching as well. And for treatment, you want to minimize your exposure to the allergen. It's kind of similar to your asthma and eczema in this way. And you can use antihistamines. You can have a regular antihistamine and oral for sick days, depending on severity. If the symptoms persist, you can try intranasal corticosteroids. And if the symptoms persist despite that, you can trial intranasal antihistamine and corticosteroid combination. If that persists, you can refer to allergy clinic. Um, but for each of these treatments, trial the treatment for a month or 4 weeks before escalating to the next type. This is typically the exam finding that you might get for allergic rhinitis is a child with allergies. So this might consist of infraorbital edema and Denny-Morgan lines, which are these lines that you get on your nose from excessive rubbing on the nose, from nasal itching, and allergic facies. You can also get as well. So this might be something you'd find, but otherwise, I think people with allergic rhinitis would present otherwise unremarkable on examination. The next condition is rhinosinusitis, so acute rhinosinusitis, which is inflammation of the nasal cavity and its surrounding sinuses, most commonly involving the ethmoid sinus. Acute rhinosinusitis lasts for less than 4 weeks, and the most common cause is a viral infection. Bacterial infections are only present in 0.2% of cases. Typically, it presents with a feeling of facial pressure or pain and nasal congestion, obstruction, and purulent discharge. I don't think I wrote this here, but typically, this may also be worsened by movement of the face, so by leaning forward. It's associated with fever, nausea, and fatigue. And viral sinusitis will typically resolve within 7 to 10 days, with bacterial sinusitis persisting for longer. Oh, I did write this here. Examination findings, erythema and tenderness on palpation of the affected sinuses, which is typically the ethmoid sinus, and clinically diagnosed based on examination and symptoms. The treatment is typically conservative, as it's commonly a viral etiology. So you can give paracetamol and NSAIDs, nasal decongestants, and steam inhalation, which is essentially exactly what it sounds like. It's just inhaling steam to clear up the sinuses and nasal canal. And for suspected bacterial rhinosinusitis, you can use amoxicillin, just like with a lot of our ENT infections. They love amoxicillin. And this is just anatomy of the four sinuses that we have. The most commonly affected in sinusitis being the ethmoid sinuses, but these are the other ones that can be affected. Chronic rhinosinusitis is sinusitis that lasts for more than 12 weeks, and it requires two of the following symptoms for 12 weeks: nasal congestion, rhinorrhea, and postnasal drip, not being able to smell, so impaired smell sensation, and pain and pressure in the face. The management is typically with nasal irrigation and nasal corticosteroids, and in severe cases, surgery. Recurrent chronic sinusitis can prompt further investigation with endoscopy or CT scans to look for abnormal anatomy. So for sinusitis lasting for between 4 to 12 weeks is also known as subacute rhinosinusitis. I believe one of the last nasal conditions is nasal polyps, which is a benign inflammatory mass that can lead to nasal obstruction and is usually associated with underlying chronic rhinosinusitis. Prominent nasal polyps may be able to be seen on anterior rhinoscopy. I believe I have a picture of it. Oh no, I don't. On the next page. Okay. Um, but basically you can just see it looking into the nose that there will be some sort of polyp or mass that's obstructing the nose. Um, Prevalence is 1 to 4% in adults and 0.1% in children, because adults are more likely to have chronic rhinosinusitis. Nasal polyps should be suspected in all children with nasal obstruction, and some adults may present with altered smell sensation. The management is guided by a severity of symptoms, so you may use intranasal corticosteroids um, to reduce swelling and inflammation. And in young children who are not responsive to medical treatment, you can perform an adenoidectomy to kind of remove the polyps. Um, and there are new treatments that are coming up, which I won't cover because they won't be on your exams. And the last section of this lecture is the throat. So the first condition in the throat is acute pharyngitis, which is an R1. This refers to inflammation of the pharynx, which is typically caused by an infective etiology. The most common cause of acute pharyngitis is viral, with herpes viruses like EBV or cytomegalovirus, or respiratory viruses such as influenza, RSV, or COVID. Bacterial infections do need to be ruled out, and the most common cause is group A strep or gas, um, which is just an abbreviation of that. Um, or strep pyogenes, and it typically presents with viral symptoms like fatigue, nasal congestion, and cough. Um, Let me actually just check something. Sorry, I keep checking things because I just want to make sure I'm not giving incorrect information. But yes, Streptococcus pyogenes is in fact group A strep, so that's good. Okay, and then a bacterial acute pharyngitis can the patient may be febrile or have a sore throat. The main goal in evaluation of acute pharyngitis is to exclude life-threatening causes such as a deep tissue infection or a peritonsillar abscess, which may cause airway obstruction and would require more intense management than what can be offered at a GP clinic. So the investigations for acute pharyngitis may include a COVID test, because COVID is one of the causative viruses, or a throat swab, which you can see for the next slide to see if we would do a throat swab or not. So predominantly the management for acute pharyngitis is supportive because the main causes are viral. So again, paracetamol, decongestants, and honey. For severe sore throat, you can consider using steroids like dexamethasone and prednisolone. And if you suspect a bacterial infection, you can wait for the swab to return. You should wait for the swab to return before initiating antibiotics, unless the patient is at high risk for rheumatic fever. So, risk factors for rheumatic fever, like if you have a rheumatic heart valve, if you've had like recent, I guess, dental procedure, and if you're immunocompromised, and if you're of Aboriginal or Torres Strait Islander origin. Otherwise, you can usually wait to initiate antibiotics. If you have a confirmed if you have a confirmed bacteria and sensitivity on your throat swab, you can initiate antibiotics, which is with phenoxymethylpenicillin or amoxicillin suspension. So this central criteria, I'm not sure if you guys have heard of it, is the kind of scoring mechanism we use to grade whether or not a child or patient will be indicated to get a throat swab for pharyngitis. Basically, this is graded on how much you would suspect a bacterial infection as opposed to a viral infection. So for each of these, you score a point. So if you're aged 3 to 14 years, if you have tonsillar swelling or exudate, and if you have tender, swollen anterior cervical lymph nodes, or if you have a fever greater than 38 degrees, and if you have an absence of a cough, these will all point to a bacterial cause. Um, if you get less than 2 points, you are not, the cause is most likely viral, and the patient would not be indicated for a throat swab. But if they score 2 points or more, then they would benefit from a throat swab and potentially antibiotics. Um, so yeah, as you can see, your tonsillar exudate and your viral pharyngitis is a lot more clean looking, although there is still pharyngeal erythema. This one has tonsillar exudate. I think that's the main difference in these. The next condition is acute tonsillitis and refers to inflammation of the tonsils, most commonly affecting children between 5 to 15 years. Again, the most common causative organisms are viral, such as parainfluenza virus, rhinovirus, and RSV, but bacteria can also be implicated. The most common presentation for tonsillitis is a fever and a sore throat. I wrote fever twice, and also dysphagia potentially. For examination, you will find that the patient will be febrile with tonsillar exudates and cervical lymphadenopathy. So I guess there's a bit of a confound between acute pharyngitis and acute tonsillitis. Um, but again, you would still use the central criteria and treat them accordingly. Um, so yeah, so you can also use the central criteria to see if you would swab an acute tonsillitis. And for the management, it's reasonable to watch and wait if you think that it might be a viral cause, and to use simple analgesia and paracetamol and as an antipyretic. If group A strep is confirmed on swab, you can give phenoxymethylpenicillin 1,000 milligrams for 10 days. Believe that is oral. And corticosteroids can help to relieve sore throat, as I mentioned earlier. If they have recurrent episodes, you would consider a tonsillectomy, but this would again be a decision made at the specialist level, so by ENT surgeon. Um, Pharyngitis versus tonsillitis. Pharyngitis, I guess this is more of viral pharyngitis. If you have tonsillar exudate, I guess that can also be. Well, tonsillitis is a subsection of a pharyngitis because it is kind of inflammation of the pharynx. So yeah, but as you can see, you do get pharyngeal erythema in both, but in tonsillitis, the tonsils are a bit more prominent and they may be exudative as well. Okay, next condition is peritonsillar abscess, which is also known as quinsy. This is an emergency complication of acute tonsillitis involving abscess formation and upper airway obstruction. So this would require very urgent management. And clinically, the child may present with respiratory distress preceded by tonsil symptoms. The buzzword is a hot potato voice. They will also have uvular deviation, which differentiates itself from metropharyngeal abscess, which does not usually have this. And I think this will be on one of the following slides. As you can see here, this is a peritonsillar abscess. Because it's next to the tonsils, it does impact the uvula, whereas a retropharyngeal abscess will be behind the tonsils, and therefore the uvula will not be displaced. The management is, as with any abscess, you want to refer to ENT for consideration of drainage, and also you would want to give IM, IV benzopenicillin, um, and admit onto pediatrics or ENT. So essentially, you want this to send them to a higher acuity setting, such as an ED. And you can switch. Okay, sorry, I should move this so you can see it better. Yep, there you go. And you can switch to oral therapy once I guess the swelling and concern for airway obstruction has subsided. But this would again be a specialist decision. So as you can see, a lot of the ENT stuff is stuff that we can do initial management for, but the ultimate decision may be with the specialist. And then this is the difference between retropharyngeal abscess, which is behind the pharynx, and a peritonsillar abscess, which is actually like next to the pharynx, essentially. Um, One of the last conditions is OSA, which is obstructive sleep apnea. This refers to a condition where the soft tissue of the palate obstructs the pharyngeal airway overnight, and this can lead to episodes of apnea or hypopnea, um, due to kind of collapse onto the pharynx, leading to obstruction, like airway obstruction. The risk factors for OSA are alcohol intake, obesity, smoking, use of sedatives, age over 50, and use of hypnotics. Clinically, OSA presents as daytime sleepiness, fatigue, snoring, and potentially periods of apnea during sleep. Um, the assessment is with a stop bang questionnaire and with the Epworth sleep study. That's like the gold standard is sending them off for a sleep study. They essentially, as part of this, they um, have a polysomnography done in the sleep lab, which just looks at kind of their brainwave activity, I think. Not super sure about that though, so don't quote me. But all you need to know that is that they need to go to sleep study. The management is a lot of it is conservative and lifestyle management. So you advise them to sleep on their side if able. As you know, with anesthetics, the chin lift, jaw thrust is the best kind of um thing for opening the airway. But if you're just lying supine on your back, then you're more prone for collapse of that soft tissue. So it's better to sleep on your sides like you do in the recovery position in BLS, basic life support. You also would want to do lifestyle modifications to address their weight, as this is a significant risk factor for OSA. And if this doesn't work, then that's when you would consider CPAP. And also, if they want, they can also get a surgery to kind of cut off some of the soft tissue in the pharynx. But CPAP is already very invasive and very noisy and can be very disruptive, especially if they're sleeping in a room with other people. So ideally, would like to stick with lifestyle management. And that is the end of my lecture. Thank you guys all for listening. Good luck with your exams for the end of the year. I know that they say fourth year is quite difficult and potentially the hardest, but I think with adequate study, a lot of the questions can become quite, um, I don't want to say formulaic, but quite something that you can definitely work your way through, as opposed to, I think, second year, where um, you either, like for anatomy, you either know the answer or you don't. So, yeah, don't stress too much, and it's good that you're starting your preparation early, hopefully. And if you are watching this early as well, make sure to come to the GPSN revision question. I think that will be part of like the MUMIS revision day that will be organized, so keep an eye out for that. And yeah, all the best and good luck and see you around.